At the virtual ESMO breast cancer meeting, we will discuss personalizing immunotherapy beyond PDL1. And the subtitle, I think, was set because by now we already know a lot about PDL1 testing, also in breast cancer. So the focus of the talk was more on the emerging biomarkers that we might use in the future. But we first discussed what the lesson we learned from PDL1. So the trials that showed that PDL1 could be useful, for example, the pivotal Impression 130 trial, where the PDL1 positive subgroup indeed benefited from the addition of atezo on top of a taxane. However, in this same trial, they showed that it really comes to details how you use your assay to test for PDL1, what kind of antibody, what kind of scoring system, etc. And it was shown by Dr. Hope Rugo at last ESMO, indeed, that if you lose an other antibody for PDL1 testing, you lose your immune therapy benefit in that particular trial. So we discussed that and all the lessons that we learned so far. And I think there's still many questions and things we should learn from PDL1. But regarding the emerging biomarkers, it's hard to make a comprehensive overview of all the biomarkers that are tested, most of them in small series of metastatic triple-negative breast cancer patients or a bit on early triple-negative breast cancer. But if you review the presentations and papers so far, I would say there are around 5 in which several trials tried to provide an answer. It's the serum LDH levels, or lactate dehydrogenase, the TILs, the tumor mutational burden. We discussed germline BRCA1 and 2 status and the MammaPrint. So on the first marker, so serum LDH, indeed, the first report, so the Keynote 12 study, showed that if in the patients with high LDH, so heavily pre-treated metastatic triple-negative breast cancer, there were no responses. And in the Keynote 86 trial, Shireen Loy at ESMO 2017 showed that LDH levels do indeed matter. So in conclusion, it's important to test patients with metastatic triple-negative breast cancer for LDH levels in their serum before you're going to start immunotherapy monotherapy. If you combine it with chemotherapy, it might not be a problem because the chemotherapy, if you respond to it, might lower the LDH levels. And then we discussed TILs. So TILs, tumor-infiltrating lymphocytes, usually measured on an H&E, so a very cheap biomarker, but you need an experienced pathologist to assess the TILs. And several trials showed that they're informative, so in the Keynote 86 trial, but also in our nivolumab tonic trial run here at the NKI, we saw that TILs were informative if you want to predict a long-term outcome on immune therapy. However, in the Impression 130 trial, the investigators showed that TILs might not be independent from PDL1. However, they used a different cutoff of 10% for TILs. So it does matter how your cutoff is, because most trials use 5% in a metastatic disease setting. And a glimpse on some neoadjuvant data provided by the Gepar Nuevo trialist showed that indeed in the TIL high patients in the neoadjuvant setting, more responses were seen with chemotherapy plus durvalumab. However, it didn't seem particularly related to the immunotherapy benefits. Then I discussed in my talk the data on tumor mutational burden, so number of mutations in the tumor. And in the metastatic setting, unlike, for example, what we have seen in lung cancer, it doesn't seem that the TMB levels are highly correlated with outcome after immune therapy, as shown by the trial list from Genentech in the phase 1 atezo study, by our in-house trial with nivolumab, the tonic trial that has been published last year in Nature Medicine, but also from the NICE Impact Initiative for Memorial Sloan Kettering in the breast cancer patients, there was no correlation with TMB and outcome on immune therapy. And at ESMO Breast, you will see data on tumor mutational burden in the neoadjuvant setting from the Gepar Nuevo, which are, I think, the data are very interesting. That brings me to Another marker that might be informative for immune therapy outcome, mutations in the germline of BRCA1 and 2. But so far, there are no data supporting that patients that carry a mutation in BRCA1 or BRCA2 have a particular benefit from the immune therapy. The benefit seems to be the same, more or less, as for non-BRCA carriers. And in the final subject of my talk, I discussed the data on the MammaPrint, usually used in the ER-positive setting to select patients for chemotherapy. But the I-SPY trialists now have data that if you not only use the MammaPrint, so the low versus high risk, but within the high risk, you can have two categories, MammaPrint ultra high and MammaPrint regularly high, or sometimes referred to as MP1 and MP2. So if you are MammaPrint ultra high, you're more likely to benefit from immunotherapy in the I-SPY trial. And I can highly recommend watching the virtual ACR presentation by Dr. Lajos Pustai. So in conclusion, I think there are many emerging candidate biomarkers to select breast cancer patients for future IO treatment. I think there's still a lot of work to do. And also, maybe the immune therapy will become like a standard of care in the neoadjuvant setting on top of 4 chemotherapeutic agents. And I think it will be a challenge to find a biomarker that can predict the benefit if you use 5 drugs with all different mechanisms of resistance, and all the chemotherapies have a different interaction with the immune system. So there are many challenges. And I think also the single cell data and the multiplex data, we can learn a lot from it. But I'm not sure whether we will have like a very easy, straightforward biomarker in the coming years.